Public health institutes like ours have no shortage of public health challenges, but we also have quite huge opportunities when it comes to new technologies, new possible solutions. So this session is really about the new opportunities we have, especially new technologies, and in particular, artificial intelligence. And of course, there are a lot of things going on the technology side. Vaccine, MRI technology, diagnostics we have touched on earlier today, and a lot of also policy innovation and so forth. But the really big thing, at least for many people over the last year, have been artificial intelligence. It's now almost a year since ChatGPT was launched to the public, and we entered kind of a new AI summer or a new hype cycle, according to some. And we entered this strange, I don't know about you, but we entered into somewhat strange combination of activities, I think. At least myself and people I surrounded myself with. On the one hand, we have the big philosophical discussion almost whether this would be the end of humanity or the way to paradise, no work, maybe just attend meetings like this, or whether, or at the same time, we did some very mundane things with ChatGPT. We spent some hours discussing these big themes, and at the same time, we wrote poems to our dogs. We made grocery shopping lists and all kinds of things that didn't really change the world, of course, but made some of us at least realize both some of the potential, but also some of the pitfalls of these new technologies. And of course, it's happened a lot also at the more practical level. For one thing, programming, graphical design, artist work, newspaper use it for reviews, you name it. And also in the healthcare sector, a lot of technologies are applied already, especially within radiology. But at least when I have attended conferences on health and AI, I find very little about public health and the role of public health institutes. So what at least is part of my inspiration for a session like this is that we need to discuss what does AI mean for public health and institutes like ours. We need to be more concrete, more practical. Of course, it's important to talk about the long-term prospects of the world, so to speak, but we also need to talk about what does it or can it mean in the short term or for us and the operational work that we do. And third, at least I think we need to discuss and learn from each other when it comes to what do we, the institutes, do next? What do we do in 2024 with regard to AI? I hear very different things, both inside our institute, very different views on what we should do, and also across institutes. Everything from let's wait and see, we can't really be a front runner in this, let's wait until there's something more ready, while others are much more, let's jump on whatever is going on. And probably, but that's something we will discuss today, something in between could be useful. So that's really the three aims of this session. One, talk about what does this mean for public health, the potential, but also the risks, of course. And second, to learn from each other about some concrete applications. And third, what do we do? What do institutes like ours do? And maybe even should there be some collaboration in the framework of IANPHI. And to discuss these three themes and objectives, we have a great panel of three speakers that have worked with different concrete cases with AI technologies. And one of them is with us today, and two are digital. So let's start with Eric Remera, Dr. Eric Remera, who's the division manager of research, innovation, and data science here at the Rwanda Biomedical Center, and also a senior researcher. And he will share with us some of the work that is done here in the area of AI. So please, Eric.
Thank you very much. Uh, I'm happy to talk today about the use of AI and in terms of public health. So maybe first of all, there are like AI is on fashion, but it seems it is still like an animal that each and everyone is looking at from far away, and sometimes you don't understand what's AI and how can it be used, or how can we make the use of it. First of all, I need to say that like when you look ourselves, the way we're created, we have like an AI integrated. Because sometimes if I know someone, I look at him, the face, and I also hear the voice. I can recognize that this person is John. This is maybe I can differentiate people. It means we are able to have to know at least have a recognition through visual, the audio, using all the sense that we have. So that's the simple definition of AI. And through that definition, now it comes to the public health and the application that we have. So the AI is like a combination of the machine and through the algorithm, which are there to do a quick analysis and provide a response at the time, at real time. So as I said, like we're recognizing people, but suppose if you see the like lion coming in the room here, I know the first thing that we do, we run. We run away because we recognize that there is a danger coming in the room. So it means also by application, we need to train our algorithm to know what is the danger, what is the good sign, what is a kind of a good, like, right direction. So when you look at, in terms of public health, we can summarize like public health issues. Maybe I may summarize them in four main points. The first will be about like pandemics or epidemic that we are facing or that we are having. So we are now facing pandemics like COVID-19, Ebola, and others, and which are coming or maybe which have been eliminated. And also, when you look at also our system, health system, we have a pressure that is coming in because we are having like all those diseases, but also the systems like it to be able to manage all those diseases, and it is a bit difficult. Here I may say that, for example, 10 years ago in Rwanda, we had almost 2,000 people on living HIV who were on treatment. And in the facilities, all the facilities had the services, but when you look at data that we have now, the number has tripled. Now it's almost 230,000. And people in the clinic, they have not tripled, even doubled. They're still the same. We are still having 2 or 3 nurses in that facility. So it means like now they have a high workload and they need to really manage those patients. So it means they need something to help them to improve the quality of care. And we can also ignore that like all the stuff that we have, the skills are not enough. So we don't have enough skilled personnel. Like in Rwanda, I'm giving an example of Rwanda. We are saying that we have now launched a program of 4x4, whereby we're seeing that we don't have enough medical staff, and want to have the enough capacity. We need to have multiplied by 4. You understand that there's some specialties where we have very, very limited skilled healthcare workers, and we can't create them in 1 year. It takes time, it takes resources, and also takes time to train them. So The other question is about like fragmented work or working silos, whereby you can see public health experts working like in one group, agriculture, another group, environments, another group, and climate change. This week we had two conferences. One, this is NPH, this one, IANPHI, and we had also one on climate change. But sometimes we don't see integration. For example, here, I'm not sure that we don't have someone from Ministry of Agriculture. So then, that's working silo. It means silos. It means it has a lot of consequences, and it reduces the interaction. And also, when you look at the budgets, especially in African countries or on low and middle income countries, we're using funding from external. And that funding reduces over the time. So then, for the health equity, we need to make sure that we are sustaining the gain that we have, and we don't have enough capacity, we don't have enough resources. So AI is there to help us to boost or to increase our healthcare services through those algorithms that we can help in diagnosis, in the surveillance, and also clinical management of our patients. So, like this, we think that using AI will help us to improve our health system and also the healthcare. So this can be used through coordinating the implementation of One Health, not considering health as one approach, but as one. And this comes not only in collecting data on the response, but also bringing together all the indicators and variables and the analysis. So AI is there to make an algorithm that don't take into account only health, but also integrating with agriculture, climate change, all those variables. Like they use the big data to come up with maybe one model. So it will also help to enhance the diagnosis and also facilitates also the healthcare workers to take decision on real time. So in terms of use case, in Rwanda, we have some use case that we can share. Like now, we have the eCard Africa implemented in the country, whereby we are using robotics for the surgery. And we are also collecting data through the collaboration with the Ministry of Health to improve the diagnosis of different diseases like cancer, TB, and others. So we're also collaborating with different universities in academia, especially to improve the health system and also the genomic surveillance. And recently, we have we have started a new system whereby we have integrated the AI solution into antenatal care services, and we are able to predict, and we are aiming to predict the risky pregnancy through maybe some questions and few algorithms that are integrated into the antenatal care follow-up. So apart from this, we are also implementing the genomic surveillance from using the wastewater, and we are trying to see how we can develop some algorithms that are based on the wastewater and pathogen surveillance to help in predicting maybe some outbreaks. That's being already implemented, and though it is still at early stage, but we are looking forward to see results soon. So talking about AI, maybe it's a good solution, but also there's some challenges that we shouldn't ignore. So as of now, it's as if AI helps to the machine to replace the human being. But it needs to be regulated because each and everyone can bring a solution. But we need to see the inputs that are coming in And because inputs will help also to design, to have through the best algorithm, we have the best outcome. So apart from this, AI is there to support the human being, but it's not there to replace him or her. So it's really important to understand that, like AI, will help us to reinforce our services, but the human being still need to be there to support the system. Thank you. I'll give floor to my colleagues.
Thank you very much, Eric. And I think you already point to 3, maybe 4 areas where there's quite some debate and hope among at least the people I discussed with. One is clinical decision support. Of course, a big debate there. Where are we really in that area when it comes to AI support? Of course, that's outside the population-based work that we do. But 3 areas that I hear many people at least think there are some immediate promise in is surveillance, different kinds of surveillance. And at least at our institute, we have started doing, I think, partly what you are saying, using AI and machine learning to be able to integrate data across sectors and non-traditional data from credit card use, telephone data, so forth, integrate that with the classical sources. We would not be able to find patterns in the noise without the machine learning we're starting to use, but now we hope that could be useful. So I think that's surveillance and modeling, forecasting, nowcasting. I think that's an area where I hear many are working. Another, maybe picking up on another thing, Eric, at least what I hear from some doing epidemiological, quite advanced analysis is that they actually have had success in using AI to support humans in doing advanced analysis. So kind of training, kind of analytical support rather than the clinical decision support. But that's also a process in the making. So that was just to build on some of your points, Eric, and maybe we will hear, I will challenge all of you afterwards to share if you have any user cases or experience to share with us. But let's move on. And next is Dr. Rose Nakasi. She's a researcher at the AI lab at Makerere University in Uganda, and I hope she can hear us, and we soon can hear her. So please, Rose.
All right, thank you so much. I can you confirm that you can see my screen?
Yeah, perfect.
All right, my name is Rose Nakasi. bring the artificial intelligence experts as well as the healthy practitioners to have a round table to be able to talk about the different contexts and how each of them can, support the other so that we augment all these solutions to support our healthcare systems is very, very important. And I'm also grateful that this meeting is bringing on board all the different stakeholders to be able to have a talk because this is very important to have if we are going to adapt some of these new technologies in an already existing public health or healthcare system. And also we know that these are new technologies, probably some of the public health practitioners don't know them. There is skepticism, especially when getting to a new change or a new technology. Continuing the conversation between the AI experts as well as the health practitioners is one way that we can be able to improve, especially if we are going to adapt these wonderful solutions. The other challenge is the insufficient infrastructure as well as the poor yet expensive network connectivity. Some of these solutions actually thrive on internet, on electricity, and where we deploy or where these solutions are needed, sometimes they don't have that infrastructure, or if sometimes it's there, it's very inefficient. There isn't sometimes always electricity, and if it's there, sometimes there is always load shedding, and if an AI solution entirely depends on these infrastructures, then we're going to realize that there is going to be a peril, but again, a consideration that we need to think about on how to go about some of these hindrances to support the adoption of the AI solutions in those areas. Again, with the change in technology, one of the things that gave us a very good but challenging experience was the changes in technology. For example, if the data was collected with a given mobile phone with different specifications, and then when it gets to testing, probably the data was collected 5 years back, and apparently there is a change of environment. Usually that is going to affect the way the performance of the model, of the artificial intelligence model, is going to work. So considerations in the way technology changes has to be one of the things that has to be included either in the model while developing the model, or something that needs to be critically given consideration because of the changes and advancements that come with technologies. And so that means that the end question that one needs to ask themselves if they are developing such technologies should be, is this technology going to always be adaptable to the different changes that come, not only with technology, but with data and all different aspects around the artificial intelligence process, and all that, again, needs to be given a lot of consideration if we're going to come up with solutions that are going to stand the test of time to provide reliability. Thank you very much. That is what I have to share. I'll pass it over to my next colleague.
Thank you very much, Rose, both for the user cases, but also for the very important list of perils or challenges that we need to consider when we move ahead. So we might come back to several of them, actually. And I'm also eager later, if we get time, to hear more from you with regard to the kind of temperature of AI at Makerere, or and how much push there is to move forward now. I hear as I said, I hear very different kind of attitudes to AI at the moment. Some people leaning back, relaxing, others moving forward on whatever horse they can jump on. So it would be interesting to hear where you believe you are. But I think both of you point to an important point that many stresses, right? That for the most part, at least, and in the short run, we expect that AI will not replace humans, but enable them to do more work or more quality work. Of course, there are already cases outside health where you see replacement or you see that there is less demand for workforce, but for the most part, that's not what we see. In programming, for example, it's where AI or generative AI have helped a lot to improve the efficiency of the programmers. At least the experts I've listened to, they point to the fact that so far demand is so high, so you just increase demand, quality, and more products out, more output, rather than downscale on the number of programmers. But there might be exceptions to that, and that might change. But so far in health, I think it's fair to say we don't see that, and maybe we don't fare for that in the short term. But happy to hear if others have inputs on that too. So thank you again, Rose. And let's then move on to the last of the three speakers. That's Professor Dr. Lothar Bieler. He's head of the chair and professor of digital global public health at the Hasso-Plattner Institute in Germany. He used to be the president of RKI and also an executive board member here at IANPHI. And this session is really his idea. So I'm just a substitute because he couldn't come and IANPHI cannot yet afford avatars, happily for me. So if you can hear us, Lothar, over to you. You're on mute, or maybe the problem is here. You seem to be unmuted. If you try again. No? Should we do one more try or go to plan B? Okay. So we will come back to Lothar. Scream out when you think it works, Lothar. Because now we have heard at least from two of the three prepared speeches and user cases. But I also asked two in the audience to be semi-prepared as a bridge over to actually challenging all of you to share the experiences so far. So if I may start with Teresa Tam, if you are willing to, if you can get the microphone and are willing to share some of the experiences in Canada. Do we have a mic? We don't have a plan C, so we need to stick to this one.
It's great. I'll share a few examples of how the Public Health Agency Canada is using artificial intelligence. So we've been, I think like many institutes maybe, initially pursued AI for academic intelligence from open source. So you can imagine automated web-based systems that can collect, collate, and analyze thousands of pieces of information from media in multiple languages, and then be able to pull it all together. And so that allows our human analysts, who are actually interdisciplinary, they speak eight different languages, as well as medical skills, in order to provide the kind of analytics that is provided to the World Health Organization as one of the inputs for their daily and ongoing 24/7 monitoring capacity. So that's fairly classic, I would say. And of course, when genomics became a thing for all of us, the application of AI and machine learning in trawling through rather massive amounts of data to spot, say, genomic indications of antimicrobial resistance in foodborne pathogens, for example, would be a fairly practical sort of concept. And I think wastewater surveillance is, partly some of the infrastructure we put in, especially during the pandemic. But there are a bit more interesting applications, I think, in the area of non-communicable diseases as well. And so we've been, of course, using mainly machine learning and natural language processing in looking at large administrative data sets that you can look at for injuries or non-communicable diseases. And depending on which program that you're using, I think that could be quite interesting. We are trying a deep learning algorithm to identify tweets in social media that report vaccine associated adverse events, for example, or symptoms that people might be reporting. And I think you can potentially use it for looking at mis and disinformation that's actually, prevalent in our social media and other environments, to try and detect some of those signals and see how one could address them, but also preventively address these kind of signals ahead of time, or pre-bunk them if you can predict what might be happening in that sphere. So I think prediction can be done for infectious disease, but maybe can be done for other areas of public health as well. And I think, there's another area that we just got into. It's the utilization of synthetic data sets. So if you had data sets where you don't want to identify the individuals, you can actually replicate and make a synthetic data set through which you can manipulate that data set for research purposes, and without compromising anybody's sort of privacy. But I think in terms of opportunity and challenges, I'll just highlight one area that we're particularly interested in is equitable AI. And by that we mean we're extremely conscious of the fact that when data that could be quite biased is inputted into your algorithms, you can actually increase inequity and discrimination. So it's something that people should be very much aware of, as well as I think we need to be able to encourage equitable involvement, use, access, and outcomes for different populations and communities that we serve. And I think some of our speakers have, of course, mentioned about the digital divide or the inequitable access to digital technologies as well. So maybe I'll stop there. Thank you.
Thank you very much. That was a lot, Teresa. Thank you very much. And you point to many additional uses in addition to what we've discussed. And just to mention one distinction that at least I have found useful when it comes to AI for our institute is that one question is how we use AI to produce outputs ourselves, and the other is how AI changes the environment and the challenges we are supposed to address, irrespectively of what means we use ourselves. And of course, the two maybe the two big ones in the short run when it comes to the environment or the challenges posed to us. One is bioterror of different kinds, but the other is misinformation. And that's an interesting case where we might see both. We might both see a much greater challenge from misinformation due to AI, but at the same time, AI might be part of the solution on our side. But again, some questions marks there, especially how that fight between then different applications of AI might turn out. But a very important topic for all of us, and we have touched on trust earlier, at least yesterday. So let's proceed to the second semi-prepared intervention from Henrik Ullum and the experiences from SSI and Denmark. Over to you, Henrik.
I think the microphone works now. Thank you. Yes, first of all, thank you for taking up this very important subject. I think we're all discussing how we can use AI better in the future. And at Statens Serum Institute, which I represent in Denmark, we are in the process of making an AI strategy. In that process, we started simply mapping up how many AI initiatives do we have in the institute. And surprisingly, even before starting to make a strategy, we identified 14 initiatives. Half of them are already in routine use, and half of them are under development. And there will be a lot of overlap with what you already discussed, in particular what Dr. Tam just said. So the things in routine use at the moment, they will be like bioinformatic and analysis. So when we are to dig into what kind of new microbes are hitting us, our bioinformaticians are really using AI as a tool. And similar, our epidemiologists, when they need to write statistical code, also that is always supported by AI. So I'd say these are not AI working areas as such. These are just areas where our human work is supported by AI. Then we have also in routine now 2 research projects, one where we predict AMR through large-scale epidemiological data, and another one where we predict problematic medication in pregnancy. So then coming back to what is our strategy, and Svøgger, you said, okay, we just run ahead on every horse we see, or should we be more leaning backwards? I think we try to be somewhere in between, but in particular we want to make it more empower our employees to seek the best opportunities they can. So what we're doing is that we have been writing an overarching policy, and basically there's a policy saying, okay, we would like to use AR, but also indicating you should be careful, do not share sensitive information. So that's the policy now. Then we are educating our staff, and that is again coming back to make our staff seeking the possibilities themselves. And then finally, we want to make a safe environment, and Dr. Tam said something about synthetic data. We're about to create synthetic data and also create a supercomputing safe environment where we can crunch the data without these important data being shared outside our own environment. So this is what we're doing right now at Statens Serum Institute. Thank you.
Thank you very much, Henrik. Great. So I think we start to get really a wide range of quite different user cases, and hopefully that creates some ideas for each of us can move forward. But what I hear now is that Lothar is ready. So can you hear us? Let's see if we can hear you now, Lothar. Over to you.
Can you hear me now?
Yeah, very well.
Oh, perfect. Unbelievable. So, okay, thank you for having me, and it's a pleasure. Thanks. So obviously we can't go over this, we have to react, and I'm certainly a friend of us taking the lead in this. I mean, we have huge possibilities as national public health institutes, and we also have huge responsibilities. So we should drive this and should not be driven by external forces for whatever reasons. I'm also part of the global initiative AI for Health that was already mentioned by Rose, and it's worth looking at the guidelines that have been developed under the auspices of this really nice and great network. So let me, in the beginning, start with opening the eye for what digitization means, and of course then in the next step what AI will mean. So there are 3 major issues with digitization and why it is so important and why we should really make use of it. The first, digitization offers us the chance to be disruptive. And this was already talked about. Disruptive meaning that we can exchange information which surpasses both institutional as well as geographical boundaries. And that was particularly meant by Eric when he talked about the One Health issue, the One Health areas. And this is something, obviously, if you have data from these various areas, multi-model analysis by machine learning algorithms is the way to go. The second issue that was already mentioned various times is automation. So obviously, we can optimize workflows by digitization. By optimizing workflows, we increase the capacity, obviously, also for doing things, because people, humans, can make more of their time devoted to their job when other analysis is just done automatically. And thirdly, we can upscale knowledge. And that's very, very important. This was also mentioned by Rose and by others. Upscaling means that knowledge and information can be spread enormously fast and into various areas. And this also gives us more time to put our efforts on our own most important issues, our public health capacities. So the challenges has already been mentioned. It's a digital divide, clearly. This is a true challenge that we have to tackle. We have to take care that this AI doesn't increase the digital divide. Also, clearly, we know that algorithm training is very much prone to produce biases, and we have to take care of that. And I also will mention briefly how I think public health institutes can reduce the bias problems. And of course, it's about misinformation. And as misinformation can be produced rather easily nowadays, it's obvious that public health institutes must know how this is done and how they can counteract it, because otherwise we would be overrun with misinformation. And I think, and Trygve and other colleagues, we already made up our mind about this. We would approach this in an issue when we're talking about the work and the duties that we have to do. Basically, you know about these 12 essential public health functions that have nicely been published just last year, also by a group from the IANPHI, led by Neil Squires. And if you look in all of these 12 different areas, public health surveillance and monitoring, health protection, disease prevention, you all know them. You will find that in each of these 12 areas, there are use cases. And I think, personally, we should very systematically look into these different public health functions and find common ground on areas where we will all work together, looking for use cases and comparing the results. So for me, there are two major issues. The issue that I mentioned already is we have to have in mind digital divide, we have to have in mind the equity issue, which obviously also national public health institutes always have on their mind. That's in our DNA, basically. And there we should take care that this equity is taken care of when we come to implement AI solutions. Bias and digital divide. But how can we solve this? And I think this is the major issue we should talk about here. It's how do we implement solutions like those that have already been mentioned by previous talks, and then how do we evaluate these solutions? Because this was also mentioned by Rose in particular. It's hard to introduce new technology if it's not accepted by the stakeholders. And you can only really get these stakeholders if they are involved in implementing it, if they are involved in the solutions, and if they are involved in evaluation. And therefore, we really should set up the issue of evaluation, and we could easily do this in a network between several national public health institutes. So we should gain expertise, and I think we as public health institutions should be really open to collaboration with external scientific institutions. That's very important. We have to learn from that. We cannot build up all the AI expertise in national public health institutes alone. and it wouldn't make sense. So I just want to show you one way how it was done at the Robert Koch Institute when I was still the president of the Robert Koch Institute in 2018. We planned a center for AI in public health research at the Robert Koch Institute. And this department, this center, actually was launched in 2021. And this particular department or center has 4 major goals to pursue. So first of all, a strategic agenda to enforce the outlining of AI research at the Robert Koch Institute. Secondly, the development and monitoring and the strategic support of new areas which are AI-based, in particular areas only focusing on public health issues, obviously. The third issue would be here to coordinate inter- and transdisciplinary research at the Robert Koch Institute, at that particular National Public Health Institutes. And then, of course, to plan and develop more research cooperations with external stakeholders. And I think what is very important here, external stakeholders should in particular be other national public health institutes, in particular in other WHO regions, because there are differences in data that are at hand, and there are differences in the mandate, in the legal mandates of some of these particular national public health institutes. But I'm absolutely sure that there is a lot of overlapping areas that these different institutions could work together, and in an approach like federated learning could really check their algorithms, prove their algorithms, whether they could also be used in these other areas upon the world. And that's very, very important. And the most important area that comes into my mind here is, of course, health surveillance and health monitoring. So we have to define the context for measurement of AI. We have to define AI applications. We have to identify AI components and functions within operational systems of our national public health institutes. We have to define outputs. That's very important, and risks. We have to identify service contexts and boundaries, and we have to identify key stakeholders. And then we have to define monitoring goals, which is very, very important, about safety, usability, transparency, reliability, the safety of patients, of people, and work process changes. And third, we have to define methods for indicator selection and categorization by reviewing expert knowledge, peer-reviewed literature, existing indicator work. And again, here I'm talking in particular about public health expertise, because so far, most applications in AI are in the healthcare sector, which is important. However, our special area is public health. And fourth, we have to define data for repeated measurement, analysis, and feedback from different user groups. And this comes to implementation. And that's very important, that we are from the beginning involved of implementation, not only in developing, but also in implementation of these issues. So the second issue I just want to stress here is we should build a network among each other. And which association is more prone to do this than IANPHI? Obviously, here we have the expertise, and we have the AI expertise, and the digital expertise in various different contexts, but there's so much expertise already. I mean, let's face it, the two people talking here about applications, user applications. My use case would be a strategic cooperation, find national public health institutes that have comparable mandates and data access, but from different WHO regions, compare the outcomes of AI-generated recommendations analysis. We should set up a research agenda for this, which should be led by national public health institutes, and we have to gain money for this. We have to apply for grants for this, and in particular, as I mentioned, for national public health institutes. Because only by doing that by ourselves and by federated learning issues among these different institutions, we can build up trust. And as we also have usually legal or clearly legal mandates, and many of our are part of the national governments. We should also be in the forefront when it comes to legal framework building up. This was also mentioned by Rose. We should give an input which legal frameworks we need to really bring forward public health expertise. And we should really lead by example. Yeah? We should lead by example. We should build up trust. We should prove that the AI tools are superior to traditional ways, and we can only do it if we do comparable analysis. And that's also something we could do in our network. Some of our institutions would do issues the traditional way, but if we could compare the outcomes, this is the best proof which is superior. Is it an AI way of analysis and finding recommendations and answering questions and analyzing information, for example, false information, or is it the traditional way? And only if we prove it, I think people will trust us, and step by step, we will move ahead. And the two use cases that I would, from my personal opinion, but this is of course something that this network should discuss about. From my opinion, one is clearly surveillance, because we all have stakes in this and we have data that we can analyze and learn from it. Wastewater was mentioned, but obviously there are much more and even more interesting and specific surveillance tools. And another topic that is also relevant all over the world would be the antimicrobial resistance, where we are also doing a lot globally, setting up national action plans, and there's so much been going on that would also be, in my understanding, a good use case for applying AI solutions and comparing them. And this is what we can do, comparing these solutions in various countries all over the world. Thank you.
Thank you very much, Lothar, both for that comprehensive overview of potential uses, challenges, but not at least the call for us to collaborate on this issue, which is really, at least most of us, I think, believe, is not really a choice whether we have to address this, but we have a choice how fast and how we do it. So now I would like to open it to the floor. Any comments, experiences, and also hard disagreements would be fun in this area. But please, start with Singapore, I think.
Hello. Yeah, okay. No, thanks very much. I thought it's a very interesting discussion, and AI I think is something that's on many of our minds because of all the media attention that's been received thus far. For Singapore, we have had some experience in it in the clinical setting. There is a project that was run that uses multiple predictive readmissions, and it looks at 1,000 different indicators and tries to predict those who would be at a high risk of readmission to hospitals, which is a big problem for many of us who run very tight health systems. And they have had quite a bit of success in doing that. But going back to what I think Teresa and Lothar mentioned on surveillance and going deep into the public health side of the house, I think it's something that even on the WHO side, the EIOS project has been also thinking quite a bit about. And I thought that perhaps I can just bring 3 concerns from the perspective of Singapore, which is a much smaller country. The first is that when we look at the options available, it was between, do we look for a commercial off-the-shelf product, or do we develop something which is more in-house? And you can imagine the pros and cons between them. One, you are dependent on a private company to support the product, and it usually comes with a certain amount of strings, right, attached to it. How they want to use the data, and we talked about data security just now as well. So I think there are some benefits in using private options or private commercial options, and then there are some benefits of having your own options as well. The second, which is really a problem for a small country like Singapore, is that is it economical, or does it make sense to develop our own model independent of the rest of the world? Or should we really join our forces in developing something together? And that's where we think that, for example, the WHO's EIOS sort of initiative is one possible way of doing it, but I think we have talked a bit also about IANPHI's ability to do some of this convening and bringing our heads together. Because having and to maintain a large language model in a small country is not always easy, nor may it be the best option for us. And the third is that when it comes to use case where there are significant consequences, where you don't want to miss the next outbreak, there's always a worry that once we go deep into some of this artificial intelligence and machine learning, we start to lose the logic model behind how it came to a conclusion. And there's this uncertainty as to will we trust what the machine essentially spits out if we don't know the logic behind it, which we're all very used to as public health physicians. So I think that we do need to think a bit about how much are we going into this space, and not to say that we don't use it, but like what some of the speakers had mentioned, know where the risks are and how we can mitigate this risk together as a community in IANPHI. Thanks.
Thank you very much. And I think just to say, at least for our institute and others I discussed with, the off-the-shelf versus how much to develop yourself, it's a challenge we will all meet in almost all of these applications. Not all, but many of those. I think the next from the audience was here, or yeah, but am I unfair against you, or sorry?
Okay, well, thank you. My name is Dayo Adetifa, and I'm the Director General of the Nigerian Center for Disease Control and Prevention. I've got a few points. Well, I'll start with the one is sort of a bit negative. Okay, so I think that AI, in many respects, is now the sort of new sexy topic that is attracting all the attention and all the money, and perhaps will stimulate another round of small projects here and there that like we typically see. Whereas AI has always been there, and indeed machine learning as a component of AI has been running around with clinical applications, perhaps mostly. I remember a long time earlier in my career, generating or sharing lots of TB X-ray data with people who developed a lot of the computer-aided X-ray interpretation devices now. But here we are, from a public health NPHI perspective, and I'm sure many of my colleagues will relate to me, we have very nascent expertise or practice of public health informatics. Okay, ultimately what you want to do is do public health informatics properly and harness all your tools, whether it's AI related or machine learning specifically, big data and all of that, and harness all those tools to generate the output you want, which is to get appropriate information to inform public health action. Now, we are struggling with even just the basic statistics, big data analysis, mathematical modeling, ML, and all of that, that you need to even make proper forecasts or adjust your multi-hazard or EPR plans for all of the data you've collected. But now, rather than perhaps some more attention go to that, the new sexy topic is AI. And again, we don't even make the distinction because ordinarily, or unless my understanding of definitions are wrong, traditionally AI was meant to mimic human intelligence with a view of sort of replacing us. Okay, machine learning is a discipline under AI, but perhaps is more related to a lot of the things that we talk about. And I think it's important to make the distinction so that people are very clear about what is being spoken about and are not swept away by the mob or by the collective discussion around AI, because that's the new important topic as well. A long time ago, I had one bioinformatician. Now I don't have any. Okay, so a lot of bioinformatics, you need AI, you need machine learning. So if I'm struggling with the basic bioinformatics, so if you come to me with a proposal for AI, and I tell you I'm not interested, you know, it's not to be offended. It's that I don't want, I want to keep my eye on sort of the basic package of things that we need to do properly, rather than running after sort of every bespoke project of funding that is available. And I think it's important. The subject is important. I have no doubt. But in the way perhaps IANPHI pushes that agenda, or the African CDC, I think it's important to keep an eye on sort of what, you know, what is core as well. Thank you.
Thank you very much. And just to say, I think we all appreciate comments like this as well. Both a reminder that AI is not one thing. Some cold water in terms of how we should proceed. I think at least many of us agree that we should be quite critical when it comes to the benefits and downside of different applications. And then, of course, the thing about capacity. One thing is, or just to say, national public health institutes, to maybe make a comment worse in a way. I think national public health institutes might not be the most popular place to work in any country for the kind of competence we're seeking. At least we struggle ourselves, right, to get competence that is now extremely thoughtful, and they can go places where they find it more fun and also better paid. So I think that's a challenge for all of us. I think we have time for one last comment,
yes.
Or maybe two. Yeah, please.
So this is Walid from the Gulf CDC. I'll bring the experience of Oman, where they have used the machine learning to reduce the amount of time needed to diagnose breast cancer during the mammography. So they were having compilation of number of reports were compiled, but there is no radiologist to read those reports, so the diagnosis gets delayed. So we have introduced machine learning to reduce the amount of time. So within hours, all the reports will get read, and they will get prioritized based on the degree of alarm-based criteria. So we have piloted first, and then we have found that it is 97, 98% of effectiveness, that it has picked up the real cases that need to be further investigation and further management. The only thing we have faced later on, because there was a software that we have bought from outside, and that software was really expensive, and sustaining the license for that software was an issue. So the ministry decided that they will abort that. Maybe they will have their own built-in software. So this is an issue that we need to address as well when we tackle, or when we decide the use of AI, is how sustainable are these softwares, and for how long we can rely on them if we are going to rely on software from outside.
Thank you very much. And then the last comment, or should go to Stephen, or Duncan. You want to?
Should I jump in?
Yeah, please start.
Sorry.
And Duncan can get the mic maybe.
So thanks a lot for putting on the session. And just to make a few comments from the UK perspective, and perhaps to echo some of the previous comments from colleagues. So it is just another kind of analysis. And as we look at investment decisions, I think, and we've done this through our public data strategy, you've also got to look at just creating the best data assets that you can, on which you can apply any of these techniques. So there's a balance between going for new analytics versus just better curation of the data you've already got. And that's something that we're definitely kind of thinking about. Within the AI space, I think you can separate it into kind of generalist applications versus specialist. And you can separate it out into solutions that are just better versions of what we do already versus solutions that are kind of generative or genuinely creative. So it gives you a little 2x2, and we're very much looking at the specialist traditional, so doing our own prototypes for to get better solutions. But then importantly, we're trying to figure out the best way to use those generative commoditized things like ChatGPT. So figuring out how to bring that in quickly to kind of superpower some parts of the organization. So we're trying to separate the way that we're approaching it. And then just in terms of your call for particular use cases that might be applicable in this community, we're putting a bit of work into the synthesis of publicly available scientific literature. That's a massive growth area for generative AI. I think it will become commoditized, but we're maybe one of those communities that could be a really active early adopter of those, and we could evaluate that. And we might be the right people to get together and evaluate that type of solution. So thanks a lot for putting on the session.
Thank you very much. And Duncan, you want to have a last word before I try to sum up very quickly?
Oh, thank you. Well, Stevens was the best last word. I think if not us, who to take this forward? But as has been made, points very well made, is it needs to be country contextual. And we need to recognise the different places and interests where people are. But IANPHI could bring together, through a knowledge hub, about what works, where we should be concerned, where we should be trying to advance, and use the network of expertise that we have in this room. I think, as Lothar says, we should embrace this without being subsumed by it or overtaken by its sexual potential. Thank you.
Thank you very much. So with that, I think we will conclude the session. I will just add one use case from the Norwegian Institute of Public Health that very much aligns with what Stephen just said. Where we have used it the most, and that was not mentioned before, and is evidence synthesis and systematic reviews. And there we use machine learning for 3-4 years. In some of the steps, we save a lot of time. It's just that those steps are not so important for the overall time. So it's kind of a moderate success. And on Friday, we got money from the Norwegian Research Council to try to integrate this into risk assessments, surveillance reports, and vaccine recommendations. So typical output products that we often deliver as public health institutes, and that integrates often data we have, the literature, but also previous assessments or previous documents we have made. So the question is, could we then move faster and maybe even better in those kind of products? So that's just another use case. I think when it comes to the 3 goals or the 3 objectives of the session, we have at least touched on all 3, and I think we have made some progress, at least in our shared thinking. One is that we now have outlined together really the vast potential benefits, but also the perils and the challenges when it comes to the application of these kind of tools, which again is not one thing. We heard in the end that it's much more nuanced, very important. Second, we wanted to hear about some concrete AI applications, and I think we have really got a wide variety here in this session, and that's probably just one subset of what is actually being done. And as Lothar is saying, and others, we might work from that to get an even better overview of what we're doing now and what could be the best next steps. And third, what should be the next steps for institutes like ours? Of course, that's extremely context dependent. But at least I think that for most of us, we have to make, at least for you that are directors of the whole institute, or me, that is director of a certain unit, we have to develop a certain attitude to how much should we push forward. At least I try to talk about leaning forward critically, in the sense that we should not sit back, but we should lean forward, but be quite critical in terms of what we introduce, what we test, and the real benefits. And then, of course, we have heard a call, I think, from Lothar very clearly, from others, from Duncan, that this might be a space where also an organization like IANPHI can really provide quite some value, although we are at different places. And hopefully we can, after this session, discuss how we go from here. So thank you to the speakers. Thank you to everyone. And now it's a break.